Thank you. My purpose today is really to talk to you a little bit about the systemic therapy landscape. Some of you and I have talked about this in clinic in your individual scenarios. Today, I'm going to try to keep it a little bit broader and show you the vast amount of work that's going into drugs now, but has also been the case over the years to give us our options in terms of therapies that we might use or recommend for each of you, and to show you that it's a very individualized decision-making process between your physician and you, the individual patient, and that's what makes medicine interesting and humanistic and fun. But also, we can't blanket statement any one particular treatment for an individual person, or sorry, for every person. It has to be really individualized. So in the next 20 minutes or so, I'll try to compact and keep it. Very mindful of the audience that some of you may not have a lot of scientific or medical training. But believe it or not, you probably know a lot more about this disease than even some physicians and caregivers just because you've done so much reading and experienced some of this firsthand. But I'll try to be mindful of not being too technical when I explain where we are with systemic therapy. So I'm obligated to share my disclosures. I will just say that a lot of these disclosures are my interactions with drug companies to try to make better drugs get to clinic. And thankfully, I tend to compel people in my arguments. And so I've been fortunate to interact with a large number of companies. And some of these are sponsorships from individual either organizations like ACCRF or others that sponsor research for patients. So what I thought would be most helpful is and some of this I'm sure you covered this morning leading up to this discussion, because Nikki does a beautiful job with Jeff of putting through a nice pipeline and program, is what is systemic therapy? What does that mean? I think number two is a big question in our field. Who needs systemic therapy? How do I make a decision or recommendation with you to help guide you to systemic treatment? I'm going to educate you a little bit about the profiling for a particular patient's ACC. Many of you know I go through this in the clinic, and I heard Nikki alluding to some of the discussion this morning. And then what are the current treatment options and clinical trials that we're excited about right now? So I think when I think about systemic therapy for my patients, I tell them there's this term chemotherapy, and I'm a little bit of a stickler on this. A lot of people think systemic therapy is chemo. I would be very careful. Chemotherapy gets sort of a negative reputation because historically in the 70s and 80s, it was really hard to control side effects. And people thought that chemo, just to quote, sort of killed their relatives or caused them to be uncontrollably nauseous, throwing up all the time, lose all their hair, fall apart. Occasionally that can happen, but that is not the typical case for modern chemo. We've come a tremendous way in terms of symptom management, and people can actually live relatively fulfilling lives on maintenance chemo. So just, I think one point I would make is demystifying chemotherapy. Again, some therapy is really intense, like bone marrow kinds of treatments or systemic treatments for marrow suppressive therapy. But cytotoxic chemo is just a fancy way of saying that a drug non-specifically gets into your system and tries to reduce how cells grow. Unfortunately, in the era of years ago, wasn't really easy to make that targetable. So the cells that grow rapidly, besides tumor cells, are affected, like hair cells and gut cells. So people lose their hair, they get nauseous and have stomach issues. Immunotherapy had a moment about 10 years ago that revolutionized cancer medicine. Immunotherapy is essentially using drugs to harness your own immune system or using immune drugs that are manufactured to attack your cancer. So it's not chemotherapy. It's essentially an immune modulating drug, and it has its own class of side effects. As you'll see, we don't hear a lot about that in ACC, unfortunately, because we don't think of ACC traditionally as a very what we call immunogenic tumor. It doesn't seem to respond as robustly like other cancers, like kidney cancer or skin cancers, to immune therapy. But that doesn't mean that it's not doesn't have an immune component. It just means it's not very immunogenic. Targeted therapy means that we're targeting something with the drug, and that often is a small molecule. We say that's like a pill oftentimes, but it can be IV. These are drugs, and you'll hear about some of them in a few minutes, that essentially aim to use proteins or small pieces of material that get into the system, attach to something, or engage a pathway within the cancer cell that tries to block function. And the one that I think you want to know a little bit about, because I think this is coming into vogue now, is the so-called antibody drug conjugate. In some ways, this is a targeted treatment, but this is an antibody. So in red, this is a structure or a protein structure. This would be bigger than an aspirin tablet, just as an example, but still relatively small, that is bound to a payload, or as I say in my clinic, a smart bomb. You can see that little cartoon with the yellow bomb attached to it. We call that the payload. And chemistry has come such an incredible way that this drug, these types of drugs, can actually get into the system through IV, reach a tumor cell, as you see on the surface of that black tumor cell, get into the tumor cell, and only under certain conditions cleave the bomb and blow up the cell. The idea is selective delivery of a payload of your choice, which could be many different types of chemotherapies or agents, by targeting a surface receptor. So you could imagine a lot of surface receptors and a lot of different payloads. And that whole construct is becoming very popular in cancer medicine now. And there are some antibody drug conjugates, or as we call them, ADCs, that are in trials and have actually looked very compelling for ACC that you'll hear about. So I think if you have a sense of these four categories, that's a nice primer for how we group drugs in general. So who needs systemic therapy? And I'm going to make some broad statements, and nothing that I say today is specific for one particular individual patient. That requires you to come and see me. But advanced, recurrent, or metastatic disease. So for many of you, you know this unfortunately well, if the tumor has come back, if we've tried traditional surgery and or local radiation options, if the cancer has spread to other organs of any type. In addition, progressing on imaging. So clues we sort of try to get, and I always say this to my patients, is about sort of individually monitoring your own imaging and seeing what the time to growth is, really sort of putting things side by side and understanding what's the doubling time, or how long does it take for a particular tumor cluster to grow or double in size. Are we seeing new sites of disease show up in a relatively short amount of time? And I have this sort of ballpark frame that when we think about slower growing ACC, as we'll hear about the so-called type 2 or more indolent type, we know on average, people's tumors grow a couple of millimeters every 3 or 4 months with no intervention, has been my experience over many, many years. And that's a generalization. But if I see something faster than that, or new sites arising, or it's a much slower process in some cases, that helps me. But I sort of keep that benchmark. As we heard from Nikki, if there's a lot of symptoms, if there are high-risk locations. Now, this is an important one. You can have a very small tumor in a bad spot. So along a nerve, in the skull base, near your spine. Meanwhile, your other friend over here has multiple lung metastases that are not on their chest wall, it's not near their heart, and they're riding along and they're opting not to do any treatment right now. So it's not just about tumor burden, it's also about location, right? It's all about location, like real estate. So those things have to be considered and should be considered when thinking about individual treatments. And then how healthy the patient is. Every human being is different. Everyone has their own medical history. People are at different points in their lives. People have different priorities in their lives. And that's a great doctor listens to those priorities. Is this person a mom? Is this person at a point in their life where, quality versus quantity is important, And again, that's not something that I need to decide. I need to listen and partner with you to understand what is important to you. Patient health status is a huge one, and your own preferences. And I'm one of those doctors that I don't ask outright a lot. I just listen to what you talk about, and then I know what's important to you. That's really critical. I can gauge from sort of, the person who comes with you, your social structure, what you talk about, where you're from, your history, what you've tried. That gives me clues as to what matters to you in life, and then I can make a better recommendation for you. And what are your concerns? As Nikki said, what are you willing to accept? There are some people who will absolutely not take certain side effects, and who knows what they are, whereas others can sort of palate anything, right? And so we just have to keep in mind all of those things when we help guide someone to treatment. So, profiling in 2026. This is probably something you spent a little bit of time talking about, but one of the things when I first meet someone, and I'm always amazed that even with some ACC experts who have been managing patients I've met, they'll come to me and this is a foreign topic. And I spend always the first few minutes saying, let's talk about your ACC, because we know a lot about how to understand your own specific cancer type. So every advanced or recurrent metastatic patient, and this goes for everybody, should have tumor gene sequencing done. Or there's a lot of ways to say that. Next generation sequencing, you'll hear NGS. But all you need to know is that somebody needs to take your cancer cells, send it to a fancy lab. There are many of them. We all use different ones, but they report the same thing, and do individualized gene testing on your ACC. That is an absolute no exceptions if you have recurrence or metastatic disease. Now, if you were diagnosed years ago and thankfully had surgery and radiation and no tumor has come back, that's not necessarily necessary. However, if something has recurred or you have more advanced or metastatic disease, it's an absolute. And we also like to do what's called surface profiling. So not just understanding what the gene changes are in your cancer cells, but what's on the surface of the cancer cells. Because remember that antibody drug conjugate, you got to know what's on the surface to be able to target. Ideally, we try to get a more recent biopsy because, as many of you know, cancer is smart and it can change over time. Although, as Nikki and many others know, it's not as dynamic with ACC. It tends to be a tumor that sort of keeps a lot of its own biologic changes even over the lifespan of your cancer. But that said, we always try to get a very recent and upfront biopsy to do the most, to get the most information that's contemporary about the cancer. The other thing is that these kinds of tests become harder if cancer cells sit for a long time. By law, they are required, all hospitals are required to keep pathology material for 10 years typically in some bunker stored somewhere. But when you pull those slides out after 9 years, that material may not yield great results. So when we talk to you all about rebiopsying and you look at us like, ugh, but it's only to get the most important information. And as many of you know, it's to understand how some of these new drugs work. So thank you in advance for that, but that's why we're asking. And it certainly will inform prognosis and therapy choice. So here's an example. These are called H&E slides. When we take out tumor cells, pathologists will section them in small slices and look at them under the microscope. This is what ACC looks like. It's not to sort of downplay, but it's actually quite beautiful and interesting. I mean, this is the architecture of the cells. There are 3 described patterns. If you are a visual person, this will come naturally to you. There is sort of tubule formation on the left. There is cribriform, which means punched out, like hole punching, and you can see the pink debris in the middle of, if you look carefully, that looks like hole punching. And then solid sheets of growth. And the most important thing to know, and this sounds somewhat intuitive, is that if you're seeing solid sheets of tumor cells, that's not so good. So one of the things that's important is we look for how much in each biopsy do we see any degree of solid growth. And many tumors are heterogeneous. The world is not simple. Tumors can grow in different patterns. The same patients, different biopsies can show different patterns, okay? But knowing that there's a solid component can give us some clues to how aggressive someone's ACC is. We heard about, or we will, that MIB is an important protein in all ACC. We think of it as sort of one of the key drivers in terms of molecular changes or gene changes that may make the cells turn on a growth switch. We can stain on the surface of cells in the dark brown there for MIB expression. And that's one clue potentially of how the tumor is regulated. I think that in some cases it informs, and it will probably in the next few years, this will be more important. But right now, in full defense, these particular findings, if reported and not reported in pathology, one could argue they don't actually necessarily right now in this moment decide or help someone decide what therapy to be on. That's going to change very soon. So I would say you all should, if you don't know that any of this was mentioned, it's very reasonable to ask your doctor, hey, what has my prior biopsy shown in terms of has there ever been solid component, or is mine predominantly cribriform? Because the key distinction is solid. You really want to understand if your biopsies have at any time shown solid growth, because that is associated with a little bit more aggressive behavior, and we'll talk about that in a second. So would be very reasonable, Nikki, to ask your doctor, and those slides are kept, and it's a relatively, I don't want to say pathology simple, but these distinctions are not that difficult, and they're made on visualization. You don't need a lot of fancy testing to know what they look like. This is molecular information that's been sort of worked out over the last number of years. But we said every patient needs their tumor profiled. And this is just an example of, in medicine, what we look at as far as tumor profiling. None of this, I don't want you to get bogged down in details, but essentially we try to understand all the different genes that are turned on or off in cancer cells. Your normal cells are their own, are behaving fine. But there are different growth signals. I sort of describe them as light switches that are turned on or off that differ from your normal cells. And there's been a lot of elegant work in these big graphs. You can just see all the different rows and columns that try to understand what genes are turned on and off in ACC. So that work was done probably about 10 years ago now. And this is the totality of now what we understand, largely from the genetic work of my colleagues and then some additional profiling work from the MD Anderson group. We know that about a third of patients have what I call aggressive ACC. My colleagues at Anderson label it type 1. They're the same thing. Aggressive ACC, and this is all of what's on this slide, is a constellation that leads to us thinking that someone has aggressive ACC, but not everybody has every feature. That's really important. It's not one piece of this that makes that diagnosis. It's a constellation. What we look for is recurrence, first recurrence in a short amount of time, a couple of years. Did someone show up with metastases at their first diagnosis? That would be concerning. Metastatic disease outside the lungs. So as many of you've learned from your own experience, I imagine, lung metastases are most common. But if we start to see bone or skin lesions or liver lesions, we start to get a little suspicious. On pathology, we look for that solid growth. As our colleagues at MD Anderson have shown, you can stain with certain markers the surface of the cells for the brown that's shown there. If a tumor is low in a marker called P63 or high in MYC, MYC is like a strong growth pattern, a growth marker. Or if, as many of you probably learned, if there's a notch mutation that activates or is turned on, any of those things as a constellation can identify an aggressive ACC. But let me be very specific. Not every aggressive patient has a notch mutation, okay? Not every aggressive patient has low P63. And tumors are heterogeneous. When you biopsy something, it's a needle in an apple, and all parts of that apple or cancer ball are not the same. So that's a little bit of a humbling statement I just made. We only get what we take out and can see. So it's not one of these things. It's me recognizing a pattern in your cancer that tells me you have type 1 or 2. But I, in clinic, always tell my patients what I think their tumor is behaving like, because it impacts what I will recommend in terms of trials or therapy. I also want you to understand that, and I just saw someone for the first time on Wednesday who I called this, there is a mixed phenotype. There are patients who have type 1 features like this, and in a second, I'm going to show you type 2, and it's hard to tell the difference. Nothing in this world is black and white, sadly. There is probably a spectrum here. And this is one reason I'm a little critical of 1 and 2, because I don't want us to forget that there's in between. And so in our field, we're working through what's the best way to label, but I like the words aggressive because it doesn't dichotomize as much in my mind. 1 versus 2 sounds very dichotomous. They're discrete integers. Aggressive sounds a little bit more permissive, like there could be a middle ground. That's my own personal reason that I don't like the 1 versus 2 designation right now. You'll notice I also said that MIB, was important in type 1. It's an important protein. And you'll see in type 2 or indolent more, and again, I don't like the word indolent. Indolent has this impression that like, oh, my cancer is not a big deal and I just can, go chill for 10 years and don't have to worry. That's almost offensive to my patients. It's less aggressive. So again, I'm kind of a stickler about this. I don't like 1 versus 2 because it's too dichotomous. And I don't like indolent versus aggressive because there's 1,000 in-between cases. So I prefer aggressive versus less aggressive, but I will use for simplicity 1 versus 2 in talking to people. Everything that we sort of talked about with aggressive, if you go to the other end of the spectrum, about 70% of people will have recurrence years later, often in the lungs, will have more of the tubular cribriform growth, not solid, be high with P63 staining, low with MYC, and not have a notch mutation. But MIB can still be present regardless, and that's going to be important. That means MIB is important across the whole spectrum. So again, this is a framework that has really come out in the last couple of years. Those of us in the know in academic medicine use these distinctions because, as I'm about to show you, it's starting to impact what treatment we might recommend. So there are certain things that look like they might be better for aggressive ACC versus less aggressive ACC. Okay, let's talk about MIB. We just said, and I think this is a key point, that MIB is important across the whole ACC spectrum, and that both types of ACC have MIB, what are called gene fusions. And this is a really beautiful, I love the slide in the middle. If you're interested in science, you'll appreciate this, but each of the colors, it reminds me of light bright, if any of you had kids who had light bright. It's very similar. So you can see a green and a yellow depending on your visual capabilities, and hopefully you're not colorblind. But the green and the yellow you can see are close together and in some areas broken apart. Those two areas highlight MIB and the partner gene, what we'll call NFIB, or just think of it as another gene, showing you that they can be broken and split apart. And what happens is piece of the DNA in the cancer cell breaks and fuses together, and that's why they're close together. But what's cool is you're visualizing that in that assay. That's really neat. So there's techniques to understand what does that mean? It means that two different genes that were not supposed to be together in your normal cells got next to each other and are telling the cell to grow. And we call it a fusion event. And MIB fusions are really common in ACC. Don't worry about this complicated diagram on the left. I think the light bright one is easier. And then turns on all this activity in the cell that we can then detect MIB on the brown stain on the surface of the cancer sometimes. So MIB is, just think of it as when it gets next to something and breaks and fuses, it can turn on a lot of activity. But it's been really hard to target because it's a very complicated biology. It's not just as simple as fusion and turning on genes. It can regulate its own self. There's ways the DNA can behave, and it can sort of bring in other proteins to work with it. It's a very complicated biology. So until last year, we were having trouble targeting this gene. So that's your primer on profiling. Everyone leaving here today should ask the question, what type of ACC, where am I in that spectrum? And you are absolutely in the right to go to your physician and say, where do I fit into this, and does that impact your treatment? Because I have had, and I'm not trying to, this is not a dig, but I've been relatively surprised in the last year that I have received second opinion consultation from patients who are managed by my colleagues where this was never mentioned. That's a disservice. It's a total disservice. I'm not going to defend that behavior. Taking 10 minutes to help someone understand the importance of your own profiling is really important so that you know why I'm recommending therapy. Every doctor should be obligated to do that who's working in this space. So, how do we measure benefit? This is a really important one, and Nikki started to talk about this. Before I introduce you to trials or medications, you'd say to me, okay, you're going to give me a drug, nothing's approved yet, true. So, what do you mean it's going to, quote, help me? Well, in cancer medicine, we need to be standardized in how we measure benefit, right? For better or worse, we have to have some group consensus on measuring benefit. So I just want you to understand a little visual and vocabulary. Objective response is a very specific term. There are criteria for when a person's cancer in total has reduced by 30%. And that is by a radiologist who doesn't know anything about you, measuring sites side by side on your scans and doing comparative measurements. You could imagine a lot of flaws with that. That's true. But for whatever it is, to hit 30% total tumor regression is what we call a response, quote, a response in cancer medicine. And we display it in the plot on the right. We call that a waterfall plot because it looks like water spilling over a ledge. In traditional waterfall plots, tumor regression, which is what we all want, is on the right and shown by bars going down. Tumor growth is on the left, shown by bars growing up. There are some more nuances, but I just want you to gauge that because if you read literature, that's sort of the basics. There are limits to this tool. For example, they only choose 5 spots in up to 3 organs. ACC can be very complicated. How do they choose the spots? We don't choose them. Some of it has to do with how easy they are to measure. If you're in my clinic, I always pull your scans up and show them. Some of them, forgive me for being trite, but they're, cute little puffy cloud looking balls of cancer. But then there are some cancers along nerves that aren't even like circular or spherical. Cancer doesn't grow in this nice little contained basketball shape. So, but that's what we have. So keep that in mind. Duration, how long does someone maintain that regression? Progression-free survival. This is a little bit of a technical one, but if you break the words apart, it means the time you are living on that treatment where you have not met the definition of progression. And progression in our world is 20% growth in totality. Someone, decided that was progression. So sometimes when you say, gosh, Dr. Hanna said we're going to treat, but he said there was progression, sometimes the benefit is still there. And even if you've met 20%, I'm going to still recommend you stay on something. That also means, think about this for a second. If you have minus 28% total growth on your scan, you don't have a response. You have stable disease. This just gives you a sense of why I have to go to the FDA and Nikki and Jeff and others to help them understand a good drug doesn't always mean that it meets the benchmark of an objective response. There are other things at play, especially when I say your tumor shrunk by 20%, you have less pain and you're breathing better. I don't care what the hell you call it. That's a response. So often my notes will say to my review, in my conclusion, because this is important stuff. You need to be standardized to get, but you got to deal with the person in front of you. We also want to understand quality of life. If you are on a therapy and your tumor doesn't, it just halts and it's not growing, but it's not shrinking, but you come off oxygen or you feel better, that's a response. We call that a clinical response or clinical improvement. So it's not so simple. I just want you to know these terms. The last one is what's called a Kaplan-Meier curve, because those are the 2 statisticians that defined this curve. Quickly, it just means that as you're going from left to right, you're following time on an axis, the x-axis, the bottom line. from left to right, usually in months or years. And as the curve goes down, sadly does the survival. So you start out with everyone surviving at 100%. The top axis of the vertical is percentage. And over time, you're seeing a stepwise decline as sadly people are either progressing or passing from a particular event. Now, this can be applied to any cancer, but we use these to communicate time on treatment and how long people are living. So when you read a website that says, and I get this a lot, Dr. Hanna, it says that at 5 years, 80% of people are alive. Does everyone die after 5 years? No. We just have to have benchmark communication to know what happens at 5 years across different cancers. And in cancer medicine, we like 5 years, we like 10 years, we like 2 years. Those are very common benchmarks that we want to understand in cancer. Okay, now the last few minutes, hopefully, and then you guys can jump in with questions, is what are the available treatment options in 2026? Well, I think we bolded this and we know this, and I'm excited to say that hopefully in another year or so, I'm going to be able to get rid of this statement. But there right now are no approved or preferred systemic therapies for incurable metastatic or recurrent ACC. Sometimes observation is reasonable. I'll give you an example later of what that means, but we already talked about a lot of this, where tumors are, how long you've lived in. Are you now symptomatic? Where are you in your life? What's available to you? Are you ready to commit to a trial? All of those things help decide. And sometimes you need a break, and observation is totally appropriate. This is another pet peeve for me. I don't like the word observation. I like active surveillance. That implies you are actively being monitored with scans. Observation sort of implies, yeah, I'm just looking at you and you're all set. No, I like active surveillance. So for me, that means you're coming in periodically for imaging and you're monitored, but you're not on any treatment right now. Just has more of, I'm a big fan of sort of like use your words, you know? If treatment is worried, or excuse me, if treatment is, I think it's touchy. If treatment is recommended, I will always try to optimize and prefer a clinical trial because you heard there are no approved options right now. Response rates to any of what Nikki said was the off-label stuff, like the vascular drugs and the things we can borrow from other cancers, is still less than 20%. Now you know what that means. That means that less than 30% growth. So not so great. Median PFS, remember we said that's the time to progression. For people who fit into more of the less aggressive ACC, the time it takes to reach 20% growth on average is about 8 to 10 or 11 months. For people with the more aggressive type, it's a big difference. It's 2 to 4 months. What does that mean? Let's break that down for just a second. That means that those of you who have more aggressive ACC, how often do you get scanned typically? 2 to 3 months. That means almost every scan you're growing, like significantly. Whereas with less aggressive, we're slowing that down. So when you ask me, is the drug working? Those benchmarks help you justify, because if you're having scans with aggressive ACC and things are stable, I'm happy about that. If things are shrinking, we're ecstatic. But just to give you that benchmark, this is sort of what we know from the data we have across all patients. This is our national cancer guidelines. These are written by experts in the field. There is a panel that comes together. This is the NCI's attempt to standardize cancer treatments in the United States for people who are more generalists. But I just highlight that this is the systemic therapy for salivary tumors, which includes ACC. And it says that the preferred treatment in advanced metastatic disease is none. And this is more something I try to educate my colleagues about in other tumor types, that this is a very much a space you have to understand in a lot of detail before you make recommendations. As you heard, there are some listed options in the NCCN, which is our national guideline, and they're the vascular medications. But I want to point out something important. There's some category numbers there. Quick comment about that. Medicare has no obligation to pay or cover, nor any insurance, for anything that's category 2B. So let me just be clear with you, because this is a big problem I have. I can prescribe, and I've done it 3 times in the last month, axitinib for a patient, cited NCCN and got a denial, appealed, got it approved for my patient, and then there was a $3,500 a month copay. but it's approved. But now I have to figure out how to help someone pay $3,500 a month. So this is the problem with not having approved drugs. Just having it in the guidelines doesn't do us any favors, frankly, either. So anything category 2B, they want to see 1 or 2A to offer coverage. So these are not even covered drugs. So if you're on these or getting access, your doctor is doing good work to help you. And thankfully, your insurer is lenient enough. But no insurer is the same, whether you have United, PPO, HM, Medicare, whatever, they all do it differently. So unless we partner with you to try to get access to these drugs, it's not guaranteed. Okay. Chemotherapy. We heard that it can be used in some patients. Who gets it? It does have a limited role in general, but as many of you know, I'll say that there are some drugs like platinum, a drug called vinorelbine, that can be helpful in certain circumstances. Like if you have aggressive ACC and your cancer is growing and you've tried all of our trial options, maybe I'm going to suggest some chemotherapy. There's also ways to make it more tolerable. We can choose some that have less hair loss or less neuropathy. We can do single drugs as opposed to 2 drugs. So there's a way, and I do at any given time have a handful of patients living on chemotherapy. The data for chemo is very antiquated. If you just squint and look at the middle numbers, the dates those were published, we're bordering on my sort of infancy in when some of these trials were reported. And so I was very careful not to say how old I was. But in general, we're using really historical data. So one of the efforts of ACCRF and my colleagues has been, can we get a little bit more updated data on how people are doing with some of these chemotherapy agents? But importantly, you got to be mindful of the toxicity concerns. And so the type of patient where chemo might be discussed is symptoms, not a lot of trial options, and more aggressive behavior. So don't rule it out. I think one of the things I've heard over the years is someone will come in and say, I'll write down chemo and I'm going to come back to it. And they go, well, I heard chemo doesn't work for ACC. And I'm like, erase statement. Let's educate ourselves that it's not always preferred, but it is a little card in our pocket if we need it sometimes. Okay. The immunotherapy story. We said that unfortunately, this is not a very immune sensitive tumor. We sometimes use the word cold. It's sort of an immune cold tumor. It's not often beneficial. And guys may have heard of this marker for immune cells on the surface of cancer called PDL1. It's a very popular marker. It's often very low in ACC. We always check, or I do, but it's usually scored 0 or 1 when we would love to see scores closer to, 20, 50, 100. Doesn't mean that once in a while someone has some immune sensitivity, but in general, this is just showing you a screenshot of trials that were done. Immunotherapy has not shown a lot of benefit. The response rates are less than 10% for most ACC groups. It is a well-tolerated treatment, which is appealing, but it's not one that I use a lot because unfortunately by itself, and in most cases, it's not all that helpful. So if I'm recommending immunotherapy, it's going to be combined with something, or it might be on a clinical trial, or you're that unique case that has high immune expression. The VEGF drugs, or the oral vascular drugs, are very popular. I'm sure many of you have heard about them. This is just a table summarizing some drugs from ACC and showing you some of the ones I'm sure you may have heard of: Lenvima or lenvatinib, or axitinib and Cyta. So these demonstrate modest response rates. Remember, we said that definition is specific. It means some growth reduction, and they are in the national guidelines, but we said that doesn't mean they're always covered. But as I'm sure I don't have to tell some of you, they are not a free lunch. There is this idea that oral drugs are easy. I don't know why. But in cancer medicine, people think oral medication, it's got to be easy. It's once a day. It's no big deal. These are evil. These are very difficult drugs because many of you all are healthy. You're living normal lives. You thankfully don't have a lot of symptoms. And then all of a sudden, I put you on 14 milligrams of lenvatinib. Your hands peel, your blood pressure's through the roof, your palate obturator doesn't fit because your mouth is on fire where you had radiation, you're not eating, you're dropping weight, you're about to call out to work, and you come in and you're like, no, I'm not doing this. And then we keep lowering the dose. And then at the one point, you're on 10 milligrams or less, and you're telling me, is this even worth it? Is it 10 milligrams? The recommended dose is 24. So I have moved away from these, thankfully, if I can prioritize a clinical trial. That said, I still use them. They're in my pocket with chemo in the setting where I need something. We haven't tried this. I'll start low. There are some people who will only start at 10 or 14 milligrams for lenvatinib. They will not prescribe the 24 milligrams. I usually go 18 or 14 and see what happens. The lowest dose I've ever heard someone respond to per Dr. Ho in New York was 4 milligrams. So I don't know. I mean, that was probably a one-off, but I really try not to go lower than 10. But I don't have a lot of patients on these, unfortunately, because the side effect profile is not compatible with what people can tolerate. Um, Here's just an example of three of them compared. There's been a lot of work in this space, including colleagues across the country to look at these different drugs. And just because we've learned these terms, the response rates you can see are between 0 and 16% if we're using our strict definition. And the so-called progression-free time is around 8 to 10 months. That means it takes about 8 to 10 months on average for someone to meet the definition of growth on these drugs. So they do something. They're doing something to slow things down, but what's the price of that? And is it tolerable for the individual person? So I think it's a long discussion with each patient about what they can handle. This I'm going to skip for now, but I just want to say that rivasirnib was a drug that many of you may have heard about a couple years ago. We were really excited about it. It was a newer VEGF drug that was more targeted. It had less side effects. It definitely does. And you can see that waterfall plot. We got some nice responses. Actually, I want to highlight this for a second. This was really disappointing. This company was a moderate-sized pharma company, worked really hard to go to the FDA with this data and got shut down. And they were basically told by the FDA that unless they do a multi-million-dollar randomized trial of this drug versus dealer's choice, which was some drugs that outlined by the FDA, they would not allow them to proceed with a confirmatory study. So that just shows you it's not about even having a drug that has activity. We have to have regulatory US regulators agree to the trial we're doing to get an approval. This was deprioritized, sadly. I really believe this was the best of the VEGF drugs we had, and I would have loved to see it move forward. A little tidbit is the company is still trying to push this drug for other cancers. If they do get an approval, they're looking at liver cancer, we would revisit this because then they would be making money. They would be getting, they would be able to commercialize, and then we could go back to them. I'm telling you guys this because this is the reality on my side, and it impacts you. Because this was not a bad drug and it performed well and had good side effect profile, reasonable to the class, but it's not moving forward, unfortunately, and there was real activity. So it's a bummer. That said, we've seen some combination attempts taking immunotherapy and combining it with a VEGF drug. Unfortunately, we didn't see a lot of synergism, right? You want to see those things work together. The immune system and the vascular system didn't really produce. This is listed in the NCCN, but again, I've tried to get this and unfortunately it's been rejected and cost prohibitive. And I personally don't do this a lot, combine them, because axitinib alone doesn't show a lot of difference from the combination. So for me, I don't want to add side effects with the additional drug if I don't think we're going to get a lot of bang. Okay, I think we're at near the end. This is my attempt to show you all of what's going on right now today in ACC. This is incredible stuff. Remember, we said there's 4 different categories of treatment for systemic therapy. These are all the different combos and tools and angles that we're taking. I think I want to share a couple of them with you because they're on the forefront of making some really impactful changes. So that's what we'll do in the last couple minutes. I did want to say that there's a different rationale for each therapy based on whether you have aggressive or non-aggressive ACC. So what does that mean? That means if you don't have a notch mutation right now, I might not push as hard for a notch pathway medicine. Now that could change in a few years, but I might prioritize certain things. We also know some of these drugs may be more important or more critical in aggressive versus non-aggressive ACC. So I always want to know the profile to help inform what drugs we're going to use. Here's the newest and best stuff in the last minute or so. We now have 2 companies that have done incredible preclinical work to understand how to chip away at that biology of MIB. And long story short, it's essentially, this is brilliant work where the fusion of MIB is happening. There are some, and I struggle with the way to make this as simple as possible. There are some flags within the DNA that are important. And they've found a way to bind the small molecule of that flag and destruct how MIB is expressed. So essentially a new way of getting at the fusion to sort of shut off MIB growth. This is the easiest way I can say it. There are two companies to know about, Remix, which is located here with REM422, and Argenta. They're also not far from us. And in presented data this year in October, last year in October, we saw pretty compelling activity for the REM422 drug. This is an oral once a day medication that blocks MIB. The waterfall plot that you now know shows you you're getting responses, which is great, primarily in the red bars. And those are patients with what we call the biomarker. What does that mean? It means we have to test your tumor, not just for MIB, but for that specific flag point that the tumor binds. Every person in this room needs to remember this when they leave today, because everyone should be tested. This drug is now prioritizing patients who have that biomarker because, as you see in red, those are the people most likely to benefit. This is showing a lot of excitement such that this drug, REM422, if you're reading the papers, was just granted breakthrough designation by the FDA. That means, what does that mean? That means that the FDA knows their data is coming and will prioritize their review for what we call accelerated approval, which means this could be one of the first drugs ever approved for ACC in the next year, year and a half. That's very exciting. So what does that mean for you? That means if you have advanced ACC, we said MIB is important in everybody, aggressive or not. So your first question on your little notepad for your physician is, should I be tested for this marker, this special MIB marker? And if not, why? Okay, you can tell them I sent you. But every single person, and many of you know in my practice, I will tell you, this is something we need to test. And I would even go as far to say that if your biopsy is really old and there's not enough material to test, it's probably worth getting a new biopsy just to know. Because what's happening here is that the response rate, if you have this marker, is approaching 30-35%. If you don't have the marker, it's 0. So you really want to know. And you don't want to go on a drug that's not going to help you with, because everything has some side effects. The side effect profile we don't have time for, but it's generally safe, it's well tolerated, and it's thankfully in general, it's a daily oral medication, but it does require that special testing. The Argenta drug will be presenting data at our national cancer meeting in June, as will updated data from this. It's a big year for cancer medicine at our cancer meeting for ACC. TROP2 and Nectin-4. I think this is an important one. This is not so much prime time yet, but it's coming. Remember I said those antibody drug conjugates need a target on the surface. We now have targets on the surface that bind what is called TROP2 and Nectin-4 and deliver, in the red little bombs, selective chemotherapy. So some drugs in this space are evolving, and so we're starting to test salivary cancers for Nectin-4 and TROP2. And I'll just give you a preview. There seems to be good expression in particularly TROP2, and there are already drugs targeting TROP2 that are looking good. So as some of you know, when I don't have a good trial option and I don't have other good options in front of me, I might recommend that we try to access an existing TROP2 medicine that's approved for breast cancer called sacituzumab or SASI, and we'll try to get that for someone. So these are also markers that I would put down on your question list to ask your doctor about. This is sort of the next generation of drugs that I think could be impactful in ACC. This one I'm going to skip for the time's sake, but just to say it's a form of chemotherapy that's bound to a special protein. And this is being studied as sort of a new version of chemotherapy against ACC. We heard about the Notch component. Remember, it's not everybody with aggressive ACC has a Notch mutation, but if they do, it can be important in the growth of tumors. A couple years ago, there was attempts to use a Notch blocking medication. This is from the MD Anderson group. Some of you may even know this drug well, called AL101. It was an IV medicine blocking notch given every week, but it had a lot of GI toxicities. Unfortunately, the company has since sold this medication, and it doesn't look like this is going to get developed further. Similarly, the response rates were a little underwhelming for an IV medicine given every week, but there was some activity here. We tried to do a new trial with an oral notch medication. Sadly, despite good preclinical evidence, it didn't really pan out as helpful in patients as a single drug, but we certainly tried. And more recently, and through the ACCRF sort of connections, I started working with someone in Arizona who's working on what are called CDK drugs. These are just, they basically block how cells grow. They're cell markers. And there are a couple of them approved for breast cancer. So what we thought was, let's try those in ACC and models, and things looked pretty good. So this led to us actually running a trial that's now using one of the cell cycle drugs called abemaciclib. What we learned, though, is it seems to be more impressive in aggressive ACC, and that may be because the cells are really faster growing and there's a lot of cell activity. So we have a trial at Dana-Farber that's using abemaciclib, which happens to be an oral medication twice a day, to treat aggressive ACC. So that's ongoing and about 50% completed at this point. Almost there. This is our last one to highlight, but it's probably the one besides the remix drug, that I want you to leave here and know a lot about. So Dr. Ferrotto down at MD Anderson as she has been doing for a number of years, continues to profile ACC, and noted that on the aggressive type 1 that she calls, the aggressive type that she calls type 1, there was expression of this immune regulator. Now, we said that this is not a very immunogenic tumor, but doesn't mean we're not looking for additional clues, called B7H4. It's just an immune marker. And long story short, it seems very, very highly expressed in the environment of aggressive ACC. And when she put it in models and gave it a drug that blocks B7H4, it worked really well. So there are some companies that have B7H4 modifying drugs. And some of us got very wind of this data and said, hey, this is important. ACC is a tumor that has no drugs, and we think this is an important target. Do you think we can explore this? And we got a yes after a lot of persistence. And long story short, a company called Mersana, which has recently been purchased and is now Day One Pharmaceuticals, enrolled aggressive ACC patients to this drug called Emily. Emily stands for emiltatug ledadotin, because emiltatug is the antibody, ledadotin is the payload, the little smart bomb. It's an antibody drug conjugate, or Emily. It binds to B7H4 and delivers a payload that blows up the cell. And as you can see from a very preliminary group of patients with aggressive ACC, it's very exciting. We're seeing somewhere around 40 to 50% response in aggressive ACC. This data will be updated to 40 patients and presented at ASCO in June of this year. And this drug is also very much on the mind of the FDA, and the information about this drug and the subsequent patients has been submitted to the FDA for accelerated review. So this is also a drug that I'm excited about, that if all goes well in the world, we could potentially have 2 accelerated approval candidates in the next year. It's still 26, but at least by 27, both Emily targeting B7H4 in aggressive ACC, and the MIB degrader or MIB blocking drug for people who have the MIB protein across all advanced ACC, because remember, MIB's important in both. That would change the game. In another couple years, you may be coming back and talking about the first approved drugs and how do we build on that story. So we're very close, closer than I think have ever been in the last few years, which is great. And this is happening right now. I can't say a whole lot. I have to be careful, but I've been privy to some of the discussions with FDA on behalf of these sponsors. The data is in the hands of the FDA, or will be very shortly, and with accelerated review, this could be something that changes the game by early 27. We're not too far from there. This is an IV infusion. It's given on a monthly schedule, which is not, I would argue, too bad compared to other drugs. And the side effect profile seems to be very reasonable. It does have some, if you stay on it for long periods of time, which in some ways would be wonderful for patients with aggressive ACC, it can cause some neuropathy like other drugs in the class. But in general, it's been favorable. There is also a unique side effect of protein in the urine, which if I didn't tell you, most patients on it wouldn't know. We just have to do things and adjust medications to make sure that their blood pressure and their kidneys are happy, but it's been very manageable. The last slide is this one, which is just to say that I always, if you've met me in clinic and you don't know what ACCRF is, and I still get a lot of those patients, and they're coming from large academic centers, just so Marnie and Jeff know, which makes me scared. I will open the website on my page. So I always show pictures, but I bring up ACCRF, I turn the screen, I point to Marnie and Jeff, I say, this is the ACCRF. I open the link. I say, look at the clinical trials. Sometimes there's stuff posted here that I don't even know about yet because Nikki gets the in. So I always empower you all. Just keep up to date with this. So, because sometimes you see something that you then want to ask me about or your provider wherever you are. So, you've learned that today. And then, of course, the last slide is a thank you, is really just to say, I'm very excited, particularly about the MIB drugs and Emily in the next 6 to 12 months. And we wouldn't be here. I know it sometimes feels like it's slow, but a lot of the work that identified B7H4 as an important target or got certain companies excited about MIB were largely because Nikki and Jeff and the ACCRF partnered with those companies to stress the importance and offer them, samples and models and really give them money and support. So ACCRF is critical in making sure we can get to those drug approvals. And of course, it goes without saying. I mean, we can't do clinical research without you all and partnering with you. Um, I like to think sometimes when have my moment, I'll say to myself, gosh, if I was going through this, I would think I would want to participate in this study to help myself. And so many of you are altruistic. You say things like, well, even if it helps the next person. I mean, the number of times I've heard that in clinic, people say, yeah, but if it's helping somebody else. And I'm like, well, wait a minute. I want to help you. It's nice to help somebody else, but you put your oxygen mask on yourself and then you put it on your little kid. You know what I mean? So like it's okay to want to help yourself. So, but it's incredible. I mean, one of the things that sponsors always say to us is it's unbelievable how fast clinical trials enroll across the United States for ACC, even though it's, quote, a rare condition. And we all say it's because of ACCRF. It's because you all have created a community, a network. And when something gets buzz, you flock in and say, we got to get this done and we got to find out if this drug works. And people just come out of the woodworks and it's amazing. And so that's so wonderful for us as researchers because then we can speed up development, right? We can get an answer quickly as to whether something does or doesn't work. And that only helps the whole community. So thank you all for that. And of course, thank you for trusting us with your care. I mean, you have a choice in who you see in medicine. Medicine is not a business, but you get to choose your doctors in the country we live in. And thank you for trusting us with your care. I mean, we know this is a rare condition and we all want you to live long and fruitful lives. So thank you so much.
For both newly diagnosed and newly recurrent patients, when would you consider tumor profiling essential? When is it typically reimbursed?
Yeah, I would always just say at any point you can ask because the worst is we'll say, well, I think I remember saying this when we were talking. If your cancer was removed and maybe radiated, and if you're, I don't like the word lucky, but if you're fortunate enough that it hasn't returned, we're not going to be doing any of these recurrence treatments. So profiling is more for research purposes. And generally, it's not favorably reimbursed in that setting because it doesn't change what we do. So I might recommend you do it if we can slide it in because I want, some people also want to know. They want to know if they have the more aggressive type because they may want to say, well, I might be mentally prepared for a recurrence within a few years as opposed to a decade. So I would argue that maybe everyone should be profiled. But in general, everyone who's had a recurrence, meaning if your cancer came back anywhere, in any context, this ACC, or spread outside your head and neck, you absolutely should be profiled. You should have tumor profiling. Thankfully, in the United States, given what's gone on in cancer medicine, tumor profiling that I'm talking about here is generally reimbursable. And in many, that's because there are many companies that do this and do it well. There are many institutions that do this and do it well. Worst case, there might be some copay situation, but generally we can help you with that and get it down to a decent price. But generally, it is covered. Thankfully, in 2026, because most cancers outside of ACC and beyond require profiling to give the best information.
Is general tumor profiling at a DNA sequencing platform sufficient, or should I seek out specific tests geared toward ACC's genetic markers?
So generally, the companies have all, thankfully, because of the world we live in, they are competing with each other to produce the best profiling. So, for example, Caris, Tempus, Foundation Medicine, Guardant. If you're at Memorial Sloan Kettering, their in-house MSK Impact. Dana-Farber used to have OncoPanel. These are all fine. They all are competitive with each other and cover a lot of different genes and profiles. So I would say any of those would be fine, and we don't need to repeat it in general. The only special case is that specific MIB test is actually something that we send out to one particular lab, and we have to talk to you about it first. So you can ask your doctor and say, well, I had tumor profiling, but there's this new MIB drug. Should I be tested for the special MIB protein? That's the perfect way to address it. But in general, any of those are fine.
If my last biopsy was 5 to 10 years ago, do I need to get a new biopsy and tumor profiling done?
So the short answer is if there's tumor available from a biopsy in a pathology place that's not too old, and I believe, I don't want to misspeak, but I'm pretty sure the trial right now says 6 years. So if it's within 6 years, but then when they get the material, there has to be, it's a really cool process. They have to be able to take DNA from the cells. So there has to be enough cancer cells in there. There has to be enough DNA that's still good. And usually that requires about 20 slides cut from it. So you can imagine, you'll hear us say sometimes, you had a biopsy, but the slides are exhausted. Slides, that doesn't mean they're going to a spa and they're tired. The slides are no longer yielding DNA, and so we didn't get enough material. So I am of the school of thought. Plus, if you got biopsied in Arizona and I'm your doctor, I got to have my team call, get the slides, 2 weeks wasted. Somebody forgot to fax. Oh, the slides didn't make it. The box got crushed. Oh, this happens every day. So I'm of the school of thought that if it's safe and feasible and you're in need of treatment, I would rebiopsy just to test for the MIB marker, because then we know the sample will be good. We know we're testing for a good reason, and as long as it's safe, in discussion with your physician. So I'm encouraging a lot of my patients now to just do the biopsy specifically for the MIB testing.
Are there any drugs currently available that can fully cure ACC?
So people ask about that a lot. So I want to make a statement. Everything we talked about today, maybe except how immunotherapy works, sadly and humbly, controls the cancer, shuts off its growth, and then I'll say things like cancer is smart. Cancer is a cell. It wants to grow. So it learns how to get around it. And one of the most important things we can do and we're doing this now with Emily, is I've had patients on it for a year, which is amazing. If they start to grow, I biopsy them again so we can learn what changed in the tumor, right? Understand resistance. So you're asking, so the humbling answer is most of the things we have there will be resistance that develops, so people will need new treatments. You're asking, is something there to get rid of it, like eradicate it? So the one thing that we had been hopeful, and there'll be more in the future, but recently about, was what is called cell therapies or vaccines. The idea that you could take a tumor, profile it really specifically, your own tumor, and create a personal cancer vaccine against the tumor. This was really hot before COVID. COVID screwed us up a little because Moderna, who was working on this for cancer, took a pivot towards a specific vaccine, which saved our planet essentially. But generally speaking, they needed to route their resources to viral mediated infection. They're now and others are getting back into the personalized cancer vaccine game. For better or worse in cancer, what happens is most of the tumors that are focused on first are the ones that are more popular, is the word I would use, or more prevalent. And that's not our fault. That's just because if the drug gets approved, there's a bigger marketability, there's more impact. We could argue the equipoise of that, but that's the way the world works. So there's a lot of emphasis on these personal cancer vaccines for melanoma, lung cancer, kidney cancer, some more prevalent cancers. I do think we will see, and I'm always got my ears out for getting that access for ACC or rare tumor. Because if that vaccine is made for your cancer and somehow triggers the immune system against those particular genes that the vaccine was designed for, you could go into almost like a curative state. You know, it's theoretical, but we've seen it with some cancers. I think the challenge has been that even with the most basic immunotherapy, we haven't seen a lot of benefit for ACC. So it's going to take some bigger tools. The other one that I was referencing was what we call cell therapy. We actually take cells out of you. We take your T cells, we modify them in the lab, we engineer them, we mess with them, make them really, really excited against a particular protein, and then we infuse them back into you. We actually tried that for ACC in a small trial a few years ago, targeting a particular protein called PSMA. Unfortunately, the trial itself and the drug wasn't so safe or viable, so they kind of closed the program. But in the future, it's possible that we might see some drugs that are taking cells out, modifying them, and getting them excited. So all that's the short summary there is immune therapies. Immune therapies that are very advanced, very personalized, very stimulatory could, in theory, put someone into a very durable remission, which could mean cure for them.